Hey everybody, this is Chris, and today we are going to be talking about diabetes. I want to remind everybody that this is not a diagnostic channel. Please do not use this information to self-diagnose yourself. Please consult with a primary care provider or healthcare team member if you do have concerns about this illness. This channel is solely for educational purposes and is only there to help you better understand the disease, processes, and the treatment to follow. Anyways, so what is diabetes? Diabetes is a chronic metabolic disease in which the body has difficulty regulating blood glucose or blood sugar. Glucose is the primary energy source used in the body, and it needs insulin to move from the blood into the cells where it is needed. So diabetes essentially is whenever the insulin is not there or lack of, or it is not working effectively, meaning it's not moving the glucose into the cells, resulting in high blood sugars or high blood glucose. So, what are some of the symptoms that you might experience with this? You got the 3 Ps, which is going to be polyuria or frequent urination, polydyspia, excessive amounts of thirst, and polyphagia, which is excessive amounts of hunger. You can also get fatigue, vision changes, dehydration, slow wound healing, increased risk of infection, and you can have some numbness and tingling develop in your extremities, particularly down into the feet. There are 2 types of diabetes. We're going to cover the type 1 first, which is an autoimmune destruction of the insulin-producing cells, which leads to little or no insulin production. The onset of this is very rapid, happens very quickly, and usually during adolescence. So, without the insulin, you're going to see a climb in the blood sugar or hyperglycemia, high blood sugar, cellular starvation because it's not getting the glucose like it needs, which the cells will then turn to a different way of getting energy, which is through fat breakdown, which leads to byproducts because it's not the most efficient way for the cells to use energy. And those byproducts can lead to their own complications, such as diabetic ketoacidosis, which we're not going to cover too much in this particular video because that is a full-on video on its own. But just know that there's no insulin because your body can't produce it because your body has destroyed it. It has recognized these insulin-producing cells as something foreign and basically eradicated it. It has destroyed them, made them unusable, unfunctionable. So what are the risk factors for type 1 diabetes? Family history of type 1 diabetes is going to be one of them. If you have a presence of another autoimmune disorder, that can increase your chances of having type 1 diabetes. Certain genetic markers or antibodies is something we can test for that would show that you may have this gene in there that will actually cause your body to recognize these insulin-producing cells as a foreign body and attack it. And then also being of Northern European ancestry. Doesn't mean that you have to be this to have type 1 diabetes. It's just the population that we see type 1 diabetes the most prevalent in. All right, so type 2, however, is an insulin-resistant type of diabetes. You still produce insulin, it's that your body is not using it effectively. The tissues have become resistant to the insulin, and it is not effectively moving enough glucose from the blood into the cells. This one is very preventable, where type 1 is not preventable. It's just early catching it early, and early intervention will prevent complications of the disease. Where this one, if you can catch it while you're in a pre-diabetic state, you can prevent this. So, like I said, this one you produce insulin, your body's not using it effectively. So, what are the risk factors for this? You have your modifiable risk factors, meaning risk factors you can do something about. And that's going to be obesity, physical inactivity, poor diet, history or smoking, excessive alcohol use, and chronic stress. So a lot of these things are things that's going to increase inflammation, increase the amount of sugar our body's taking in, whether it be you're actually consuming it or you're causing a hormone in your body to release, causing your blood sugar, your body to push more sugar into the blood because of that. Or other things are going to be due to like vascular issues. Your non-modifiable risk factors is going to be being over the age of 45. Metabolic syndrome, which is an association, it's a syndrome that affects metabolism. And generally you see the syndrome whenever you have like hypertension, dyslipidemia, and obesity all together. It puts you at a high risk for developing this. A family history, gestational diabetes, which is having diabetes during pregnancy and only during pregnancy. So you can get this type of diabetes at any point in time during your pregnancy, but generally whenever the pregnancy stops, you give birth, your diabetes should go away. Sometimes it doesn't. It becomes type 2 diabetes at that point. If it does go away, you are still at risk for developing type 2 diabetes. Having fatty liver disease, pre-diabetic or diabetes, and being African American, Latino, Native American, Native Alaskan. So these are like, just I said with the Northern Europeans, you can get diabetes with any race. It's just this is the most prevalent population to get diabetes. So what is the diagnosis of diabetes? Well, for type 1 and type 2, it's going to be seeing if you have high blood sugar. You can do a random plasma glucose check, which will show basically just a random finger stick, nothing done special. And if you have a blood glucose over 200, it puts you at the suspicion for diabetes. That's not usually how they all diagnose it. The biggest thing that we do for diagnosing is going to be the fasting plasma glucose, which is whenever we make somebody fast, not eat for 8 hours, and then they come in to have their blood sugar drawn. And if it's over 126, more than twice, meaning 2 separate tests, not 2 checks right after you do one set of fasting. 2 fastings, 2 tests, both of them over 126 generally will diagnose you with diabetes. You can be considered pre-diabetic if you get between 100 to 125. Now, there is another test. It is A1C, which kind of gives us an idea of what your average blood sugar is over the past few months. An A1C over 6.5 generally means diabetic. If it's 5.7 to 6.4, that's generally pre-diabetic. So there is one slight difference on one more thing. With type 1 diabetes, you are going to also get additional testing because both of those just tell you about the blood sugar, but one doesn't tell us if you're producing insulin or not. So we would do an antibody test to see if you have these antibodies that may have ceased insulin production because they've destroyed the cells, or you'll get a C-peptide test. What C-peptide is, it is a byproduct of insulin. And if you're not producing insulin, you're not going to have much C-peptide inside of you. Where type 2 diabetes, you do produce insulin and you will have C-peptide. So if you get a C-peptide test and it comes back super low, then, or not at all, then you have type 1 diabetes versus type 2. Also, another good thing that's going to help judge that is age. You can still get type 2 diabetes at a young age, but generally type 1 diabetes is going to develop at that beginning, at that earlier on in life, adolescence, and that's going to be kind of our first thing to kind of cue you in. So treatment for type 1 diabetes, exercise, diet, insulin. They have to have insulin because their body does not produce it. However, treatment differs whenever we're talking type 2 diabetes. And that's because we do produce insulin, but it's not being used effectively. We have more options. So our treatment is going to be trying to target our A1C at about 7 or less. It's going to differ from every person. It depends on what the doctor feels is most appropriate. That's a very commonly used one, 7 or less on the A1C. And then also trying to flatten out blood sugar spikes or drops, meaning whenever you eat, we don't want to see a giant spike. We want to see like nice little gentle curves or a nice flat line at a good spot on blood sugars or blood glucose levels. So the number one thing we're going to ask people with type 2 diabetes to do is lifestyle changes. You're going to have changes with your diet, exercise, making sure we're doing that. If you're smoking, we're going to try to tell you to stop smoking. We're going to try to get you to stop drinking. We're going to ask you to have an adequate amount of sleep and help try to manage your blood pressure, and cholesterol. Why? These are our modifiable risk factors. If we can modify these and treat the disease either before we start having to give medications, that's what we want, especially in the pre-diabetic stage. If we can prevent it from happening and not have to give you medications, that is the best case scenario. If we've tried these and they fail, generally we will start you on a medication called metformin. It is our first line treatment for diabetes, and this just helps increase the sensitivity to insulin in our body, and it's generally well tolerated. However, there may be some people that aren't offered metformin, and that's generally because your kidneys are not doing so well, because metformin for some people can increase the risk of kidney injury. And you'll generally get your kidney labs checked whenever you're getting before you started on metformin, just to make sure your kidneys can tolerate the medication. We're not trying to make things worse. Whenever we give out medications, we are trying to make sure that the benefits outweigh the risk. And if your risks are too high, we will not start that medication because it goes against the point. So whenever we start on metformin, continuing with the modification to the lifestyle changes, starting on metformin, if we're still not seeing a change in the blood sugar, generally we can start up a second agent. That agent, that's going to depend on what that patient's needs are. We have a bunch of different ones. Some help out more with like heart, fat, kidneys. Just depends on what that particular person's needs are. It's going to tell us what kind of agent is used then. If that still doesn't work, then generally we'll push off onto insulin, which is usually our last line of defense, or we'll use it if our blood sugar is just outrageously high and we need it brought down quicker. So, diet. This is the biggest thing whenever we talk diabetes, diet and insulin. So, diet, you're going to see a lot of whole foods. You're going to see unprocessed fruits, vegetables, whole grains, lean proteins. You're going to want to take in healthy fats, which is going to be the HDLs whenever you're looking at lab work, which is going to be contained in avocados, nuts, seeds, olive oil. And the biggest impact on diabetes whenever we're talking diet is carbohydrate management. Carbs. This makes the biggest impact on your blood sugar because this is where our glucose comes from. Other things is going to be high fiber, which is going to have whole grains, legumes, non-starchy vegetables. And the reason why fiber is important is it slows the absorption of the food and carbohydrates, leading to slower intake of the glucose, slower rise in the blood sugars. Portion control, making sure that we're having a balanced meal, not overeating, not undereating, and then also trying to make sure that we're having regular meal times or a consistency in how often we're eating and how spread out these meals are to allow for slow gains in our blood sugar versus stacking 2 meals on top of each other and having a basically large amount of carbs in our body at one time. Allow insulin to try to do its job in between the meals and treat what it can't handle. Now, the other big thing about diet, this is probably the most complicated part of it, is glycemic index. So what a glycemic index is, it is a number that we have put on food that tells us how fast the sugar will hit our blood and cause a spike. It'll tell us how sharp that spike is going to be whenever it happens. So a low glycemic index will have a smaller bump in our blood sugar, where a high glycemic index is going to have a very sharp, rapid spike in our blood sugar. So a low glycemic index is going to be like less than 55. It's going to have a slow, steady rise. And this is going to include most of your fruits, vegetables, beans, oats, whole grains. Moderate glycemic index is going to be between 56 and 69. And it's going to have a smaller, a little bit higher, faster rise than you will with the lower one, with the low glycemic index. And this is going to consist of white rices, sweet potatoes, corn, some breakfast cereals, not most. And then you have the high glycemic index, which is going to be like over 70. This is where you're going to see that very sharp spike in sugar, blood sugar. And these are the ones that you want to try to avoid with diabetes. It's going to be like your white breads, your cakes, your pastries, donuts, most of your sugary cereals, which is the majority. And you can get these numbers for a glycemic index through a database. It's all on the internet. It's in apps. You can type in the food that you're looking at. It'll tell you a number. That number tells you its glycemic index. However, glycemic index isn't the biggest thing to be looking at. It is very important. It'll tell you how, like I said, how fast your blood sugar is about to go up. It's not going to tell you how much. Glycemic load, however, will tell you or give you a pretty rough estimate on how high your blood sugar will get once you consume whatever you're doing. It's used to help judge your portion sizes and maybe keep the everything within a range so that your insulin can handle it. But you do need glycemic index to calculate the glycemic load. So to calculate the glycemic load, you need the glycemic index multiplied by the amount of carbs that you're about to consume in grams. And then you're going to divide that by 100, and that gives you your glycemic load. Now, the glycemic load, like I said, it's going to tell you how much your blood sugar is going to go up, which is very important. It can tell you a little bit, but this is mostly judged off of the glycemic index, how fast it's going to go up. That's mostly a glycemic index. You're not going to get too much of that with the glycemic load. But if you stay within your glycemic load, generally your treatment's going to be enough. So a low glycemic load, which should be the majority of your meals, is going to be 10 or less. You have a medium glycemic load, which is going to be 11 to 19. And generally, you want to try to stay away from this as much as possible, unless you're very active or you're a very carb sensitive person. And what I mean by carb sensitive, I mean that whenever your body takes in any amount of carbs at all, your body immediately will dump a large amount of insulin. And if you're not eating enough, you can become hypoglycemic because your body, like I said, you do still produce insulin. It's not used effectively. So some of these carb sensitive people may not be able to tolerate a low glycemic load. However, you should avoid a high glycemic load, which is going to be 20 or more. Most people, pretty much anybody that is diabetic, does not need a glycemic load of 20 or more. So you can actually get a glycemic load on some of these apps and other databases. All right. So there are other things that can help you manage your diabetes and some of the apps and technologies that's out there. One of them is going to be a glucose monitor, a continuous glucose monitor. It'll give you real-time alerts. It'll trend your blood glucose. It'll integrate with your phone, watch, and pumps to where you can see all the data from many different places. And not only can you see this data, you can actually watch the trends of it and send it to the doctor. They'll be able to see, like, if you're having any troubles, you'll be able to show them what's actually happening to your body. And they can make better judgments on how you need to be treated or what adjustments you should be taking. Another thing it can do is reduce the amount of blood finger sticks that you're having to get, where you, like a manual glucometer, you would have to poke your finger every single time. This one is only a patch you would wear and change out every few weeks. Insulin pumps is another thing that you have. It can work very well. It delivers insulin autonomously. Some of these will work with a continuous glucose monitor to where it all manages itself for the most part. And the good thing about one of these pumps is they can do a very good job at keeping your blood sugar nice and steady and prevent a lot of those highs and spikes. I do know that at one point in time, there was some malfunctions happening with some of these machines, and they were causing some overdosing on insulin and underdosing on insulin. It usually will let you know when this happens. However, it does require you to probably go see a doctor and go to an emergency room, or at the very least, keep a very close eye on your blood sugar. I don't know that this has been continuing to happen. I think that this is mostly something that I heard about probably 8 years ago, but I haven't heard too many instances of this happening again. Just know that something that is automatically giving you something can fail, whether it just stops giving you blood sugar altogether and then you still have to find a way to get blood sugar, or maybe it accidentally does an overdose because something was wrong with that particular pump. However, we can still treat it. It's just, it can be a very scary situation. There's also insulin smart pens out there, which is kind of like the manual pens, but they do help keep a log of how much insulin is being delivered. That way, if your doctor's asking how much insulin you're using, you can have a log showing how much insulin you're taking, how often you're taking it, and how long it's been going on like that. So there are also apps that will help track the amount of carbs you're intaking as long as you're inputting all the data in there. It'll keep track of your blood glucoses, especially if you're using it in conjunction with your glucose monitoring, the continuous glucose monitoring device. And then also keep track of your exercise, because if you exercise more, you use more blood glucose. It actually increases the effectiveness of insulin, and you may not actually need to take as much insulin, which is what's nice about something like this. If you maybe forgot that you walked 5 miles today or didn't realize how much you actually went, and you were about to take like a large dose of insulin, you may want to hold off on some of that a little bit, depending on what your body is like. There are some complications and risk factors that come with diabetes. Of course, the most obvious ones of the acute side of this is going to be hyperglycemia and hypoglycemia. That's because the shunting of the glucose isn't happening, or happening too much, depending on what just happened, like if you've given yourself too much insulin. So high blood sugar, low blood sugar. Diabetic ketoacidosis we briefly talked about, and that's primarily prevalent with type 1 diabetes and can happen with type 2 diabetes if you're high enough insulin resistance and non-compliant with taking your insulin. And the reason why is diabetic ketoacidosis can only happen if the glucose is not shunting into the cells, meaning you don't have the insulin available to move the glucose into the cells, which is why it's higher prevalence in type 1 diabetes. Then you also have hyperosmolar hyperglycemic state. HHS is the easier way for us to put it, which the biggest difference between this and DKA is there's no ketones. There is insulin that's there. It is pushing glucose into the cells, but you're not putting enough insulin in there, and there's not enough glucose going into the cells. The cells aren't having to create ketones, but you're also not managing your blood sugar. So generally this will happen if your blood sugar is over like 600 for a very long time, and it will result in fluid shifts, dehydration, electrolyte shifts, very high serum osmolarity, which means thick blood. But the biggest thing, no ketones. Both DKA and HHS are very dangerous and can be lethal. Then the other kind of more acute side of diabetes is diabetic ulcers and osteomyelitis. Diabetic ulcers generally happen down there in the feet. This is why it's important to make sure that you're wearing proper footwear, looking at your feet, inspecting it for any cuts and open areas that you need to keep an eye out for. If that goes unmanaged or unnoticed for long enough, the infection can actually spread into the bone, and that generally is not treatable except through amputation. Once you get the infection down into the bone, we don't have any good ways to treat that other than getting rid of it by cutting it off. So that's why a lot of there's a lot of amputees with diabetes, is because they've got these diabetic foot ulcers and it went to the bone and they needed that cut off. So some of the other chronic complications that you're going to notice with this with diabetes is going to be autonomic neuropathy, which can affect digestion, heart rate, bladder's function, meaning you can retain urine and you can increase the amount of times you're going, and sexual function. Sometimes things stop working. Cardiovascular diseases, I lumped all these together because there's a lot. You have peripheral arterial disease, coronary artery disease, myocardial infarction or heart attack, depending on what you know it by, heart failure, cerebral vascular accident or stroke, transischemic attacks or mini strokes, chronic kidney disease or, kidney injuries, end-stage renal disease or kidney failure, and peripheral neuropathy, which is that numbness and tingling to the extremities, particularly down into the feet. Remember that type 2 diabetes a lot of times can go unnoticed for a long time. Usually when you start noticing, it's because these symptoms start popping up and they take a while to develop. But once they develop, they are there. They're not going anywhere. They stay there. So trying to catch some of these things earlier is better, which is why following up with your primary care provider regularly is important. You can also have changes in vision. Leading cause of blindness is caused by diabetes. Retinopathy, glaucoma, cataracts, and macular edema is other things that diabetes can do with the eyes, and it can increase your risk for gum disease due to the higher glucose levels in the saliva, which increase bacterial growth, and you have a decrease in your immunity. So it's very important to make sure that we're checking our feet, doing foot exams on ourselves, being seen by our ophthalmologist and making sure that our eyes are nice and healthy, seeing our dentist and making sure our gums are well taken care of, brushing your teeth twice a day, monitoring the blood pressure, and also getting the blood work that your doctor needs. So following up with your doctor, getting the blood works, checking your A1C, checking your kidney function, checking your lipid or fat panels. So I think I hit everything that I needed to and tried keeping everything as short as I possibly can while hitting all the most important topics. Hopefully I didn't miss anything. If there is something I missed, I'm sorry. Let me know. But anyways, I will continue on with this. I will try to have an episode out once a week. So you should be seeing me again next week. Hopefully this was good and you understood everything. If there's something you like about these videos, let me know so I can continue doing those. If there's something you don't like or something that just keeps you from, like, it's making it hard to understand something, let me know. I want to be able to correct this. This is so that I can help you and the community understand these disease processes, because that is the point. I'm not making anything off of this other than helping the community understand some of these things. And if I can better this, I would love to know what I need to do so. Anyways, y'all have a wonderful day or night, depending on where you're watching at in the world. And until next time, I say goodbye.